Okay. Hello, everyone. This is the panel of the survivors. Actually, in every other normal room would be a nice crowd, but here they gave us the plenary. So my name is Nadav Davidovitch. I'm a public health physician. I'm involved in this conference for now 18 years. It's crazy. First I want to thank, of course, the organizers. I want to thank Professor Anat Rosenthal, Professor Maya Negev. Unfortunately, she had another commitment, but she's also from the organizers, and also Natan Lev, and all the wonderful team that came from Malawi and from other places. So this is part of the health sessions. This session is about local food systems, nutrition, and health. As you see, it's not exactly, but quite close, because we made also a small presentation. Yahel, we need to have you presenting another time. No, I'm kidding. In this session, we're going to discuss, among other things, the critical role of local food. And I urge all of you to sign for tomorrow field trip, because in many ways it will be a continuation. We're going to visit tomorrow different Yerucham that used to be called, what was called a developmental town in the 50s. And then we're going to visit a Bedouin village and to see their local food. And finally, we are going to finish at Ben-Gurion University main campus. We have a teaching kitchen there. We'll be showing you some of our work that we're doing in the Negev. Some of us are traveling also next week to the Teaching Kitchen Collaborative in California. So I think we are ready to start. And our first speaker is Mr. Victor Kanyema for Partners in Health, Malawi. We heard about Partners in Health quite a lot. And first I want to thank you for all the work you are doing. And you're going to present on a Partners in Health field-based experience in integrated agricultural innovations. So please, the floor is yours.
Good evening. My name is Victor Kanyema from Malawi, particularly from Partners in Health. So to start with, my background is community development, but I have also done management studies at Malawi School of Government. So I will take you through some experience that I've had through the subject that I highlighted here. And behind you, I need to indicate in advance to say this is non-academic. This is purely from my experience having worked with the communities in Malawi. So the title of this particular presentation is Field-Based Experience in Integrated Agriculture Innovation, a pathway to improve to livelihood and health outcome for vulnerable rural households in Neno, Malawi. Okay, thank you. In terms of what is expected to be here today, includes social determinants of health and climate change. I'm also going to highlight a bit about Partners in Health as an institution that was implementing, specifically through the program popularly known as POSA, or Program on Social and Economic Rights, and also the Goat Seed project that brought me here as an initiative that I would like to share more about. To start with, would you say what are the social determinants of health that affects the global health? In as far as Partners in Health is concerned, there's a belief to say it is not possible to achieve global health if we cannot address the social determinants that affect that particular health. So these are non-medical factors that influence health outcome globally, and they encompass the following conditions which individuals are born, grow, work, live, worship, and age. That's according to CDC 2004. These conditions are shaped by a broader range of forces and systems, which include economic policies, climate disasters itself and pandemic, and also environmental agendas, social norms, and the political systems. Just to unbundle a bit about these broader areas that I mentioned, what is involved when it comes to economic policies and systems? We're looking at the rules and structures governing resource production, distribution, and the consumption, impacting healthcare financing and access globally. While on developmental agenda, we're looking at strategic plans and priorities, which may also include sustainable development goals. We're also looking at social policies as formal guidelines and laws promoting social welfare, such as universal health coverage and education policies. So, in as far as Partners in Health is concerned, we believe that if we are to achieve health, we need to tackle all these areas being mentioned. Now, what is Partners in Health? Or who are we really? In other ways, Partners in Health is an international health institution which is also operating in Malawi. In Africa, it is in Malawi, Rwanda, Lesotho, Liberia, and Sierra Leone. And its mission is to provide preferential options for the poor in healthcare by making sure that it achieves the overall overarching goals that brings the benefit of modern medical sciences to those most in need, and also to save an antidote to despair. In other ways, what Partners in Health focuses much on is to make sure that all the services that are provided in towns, they should also be accessible in rural sites or in the settings of poverty, because every life matters. So this is the belief that Partners in Health also promote in Malawi. In Neno, we are in a very rural setting, and Neno has so many challenges, and Partners in Health felt being in Neno is the best way to save and treat vulnerable populations and help them be exposed to services that can improve their health. And that's the information about our district, Neno district. That's map of Malawi, and that's also the map of the district. My colleagues, Drs. Henry Ndindi and Moses, I think at some point they already highlighted more information about this. So allow me to skip this particular slide. Partners in Health as an institution also have specific theories of change that they promote whenever it is working globally. And we have what we call 5S of PIH approaches. And these 5As looks at the staff as a human resource, because you cannot operate, you cannot provide better services if you don't have trained or if you don't have human capital that can discharge or provide services. We also look at staff. The staff include equipments and gadgets that helps the human resource to deliver various services to the vulnerable population. We also looked at space as in infrastructure development, where various human capacity operates from as a facility that are used to deliver various services. System, by making sure that we collaborate with various actors that are also in the same industry of health. And the social support, that's where a department that I'm coming from. Largely, POSA is largely associated with this particular, POSA largely comes from this aspect. POSA was born in this particular area because it exists to make sure that we address social determinants that affect health by making sure that we interrupt the cycle of poverty and diseases that affect the most vulnerable populations in the settings of poverty. Whenever we are discharging our duties as POSA program, largely we strive to build resilience of the communities that we serve. We don't only look at the immediate, we also look at the medium and also long-term needs of the vulnerable population that are saved in the catchment areas. Some of the initiatives that Partners in Health through POSA has implemented for years includes patient care. Patient care is so wide in as far as PIH POSA concept is concerned. Patient care looks at making sure that we provide referral services to patients in terms of transportation as one way of promoting adherence to treatment. At the same time, we also look at other immediate services such as inpatient support, like food packages, to make sure that patients are provided with what it takes to make sure that they get the best treatment in the various health facilities. Another area includes emergency preparations and response. This is largely connected with climatic disasters. As Malawi is not spared from all climatic challenges, and we have been hit several times, which include dry spells. And Partners in Health believe that through POSA, we need to make sure that we support the communities to develop resilience and also help them develop capacities that can help them respond well whenever disasters occur. Vocational support, this largely target the most vulnerable young people, people that do not have the capacity to go back to school. But if we cannot do anything about them, for sure, we are opening a can worm of challenges that will impact on their health. So Partners in Health believe in providing relevant skills that can help young people develop capacities to sustain themselves and also save themselves from healthy challenges. Housing support is another area of support in as far as POSA is concerned, as one aspect of social determinants that affects health. There are people in the communities that could not afford a decent home. Through POSA, we are able to construct decent homes and promote dignity and help vulnerable people have or come from decent homes that preserve their right to health. Not only that, we also have an agricultural initiative that promotes livestock production, crop production, and also citrus trees that can be used in future. And the last one include educational support for children with disability, secondary school students, and also we're able to even support some students to attend university education. Today, our focus is only on agriculture-related intervention, emphasizing the livestock production. What is goat seed about? As we all aware, that seed is meant to multiply. So we're using the same concept in the context of goat initiative. So this particular initiative was introduced to make sure that we support 1,228 community health workers that are operational in the district. Currently, we can say the community health worker initiative phased out, but it was one of the tools that Partners in Health was using as part and parcel of making sure that we promote health in the local settings of Neno district. Their role include providing health education, screening, referral, and accompanying patients to make sure that they should not default from getting various treatment in various health conditions that affects them. And in terms of their population, 67% of them were women with the responsibilities to take care of their families, and some of them having extended families. So Partners in Health felt, much as they are serving others, they also need to be saved because there was a gap. Of course, they were able to receive small stipends, but the stipends was not enough. It was not good enough to sustain their families. So accompanying them with this initiative was a plus, and at the same time motivating them to work hard to make sure that they save their communities. Where did we got this particular initiative called Goat Seed Initiative? The Goat Seed Initiative in practice was a lesson that was drawn from this particular year, 2013, where a small number of goats were given out to some villagers to manage. And because of the successes that were drawn in that particular initiative, the communities felt if we can grow, if we can enlarge this particular initiative, can also impact lots of people within the district. So this is where it gave birth to support a good number of health workers to that tune, so that they can also be saved in the district. Happy to provide selected vulnerable community members with goat to raise, which means, which in the end, it is passed on to another member of the community. For instance, you are provided with 3 goats, but make sure that you should also pass on the same number that you have received. By doing so, it becomes a self-sustaining initiative that can impact the entire community. So, in collaboration with community health workers, Partners in Health through POSA program, we discuss and agree to say if we are to invest or focus on Goat Seed Initiative, it can save the community and meet their needs. What were the specific objectives under this program? The following 4 objectives were created, and one of it, starting from the first one, we wanted to make sure that the community health workers have additional source of income, because goats can be sold. If they multiply, can also be sold. To improve community health worker livelihood through goat layering and value-adding activities attached to goats. We also felt that, yes, much as they are raising goats, but that can also be an opportunity to enlarge their farming inputs by whatever things they collect from goats can also enlarge their farming industry. To improve food security and nutrition status through access to milk and meat was also the objective. and also empower women to become financially independent from the goat proceeds. As they multiply, you can sell. Those were the 4 objectives that the program was striving to address. For the program to succeed, there were several stakeholders that Partners in Health through POSA was working with, which include the community health worker themselves as a board of volunteers, as primary beneficiaries. At the same time, worked with the local structures. These are the gatekeepers or the owners of the villages, the communities. We also worked with the Minister of Agriculture, Minister of Health, and also the Office of the Social Welfare. Because all these initiatives, because they are related to social well-being of the vulnerable population, you cannot work in Malawi without collaborating with these particular partners. So through the POSA, we collaborated with all these structures. And there are also other non-state actors that also form part and parcel of this initiative, because we could operate in the same catchment area. For your information, because the health workers were found almost in each and every villages. And it's not only PIH that operate in these villages. There are other organizations that were also having their intervention. So Partners in Health through POSA, in collaboration with the program itself, we felt we can also support one another by supporting the initiatives that are there in the district. What were the key drivers of the project, or what were the planned activities that were done in that particular area in the process of executing the Goat Seed Initiative? The first initiative was to introduce the program to the District Executive Committee. The District Executive Committee in each and every district has the power to approve or disapprove an initiative. So they add additional information or things they expect you as an implementer to achieve in line with the governing policies that exist in that particular district. Community stakeholder meetings that targets the community health worker themselves, consulting them, because they also become part and parcel of the initiative. Therefore, their voice matters. So it's not just a question of coming in, parachuting, we brought this, no, but sitting down, discussing, and agree to say this is how we're going to implement the initiative. We also included goat management training because we felt we cannot supply the goats without providing basic knowledge in terms of managing the goats. Yes, we know. Oh, 2 minutes. Oh, thank you. And at the same time, we also work together with the Minister of Agriculture, identifying the light seed that suit their needs and distribute to relevant beneficiaries. Monitoring of the project was also part and parcel so that we can draw lessons from the initiative, what works, what do not work well. So those were the key initiatives that we were able to implement in the process. What leads to the success of the project? So these are some of the lessons that led to the success, which include selecting the right crop of the goats that are healthy. And all these goats were identified within the same catchment area. No goats were procured outside the district or the catchment area. So all the goats were sourced within, which gave the farmers an opportunity to raise resources, training in livestock management and feeding, and also knowledge in terms of the right time for heat. Formation of corporate groups was another opportunity that led to the success, because apart from that, they were also led to, it also facilitated to the development of what we call village saving loans. And the farmers, apart from raising goats, they were also able to share resources, loans that support their families. farmers were able to, okay. Farmers were also able to use manure to apply in their families, in their garden, vegetable gardens, which include maize gardens. So apart from raising the goats, the same initiative has also contributed to improved crop production in their families. And not only that, it has also saved the interest of selling excess manure to other farmers that that were interested to use the same manure. So, in other ways, these are some of the lists that I can also show as part of the lesson that we do in the process. Because of time, and I'm sorry, I may not manage to present everything, but this is a summary of some of the lessons that we managed to draw in the course of implementing the Goat Seed Initiative in Neno, Malawi. Thank you for listening.
Thanks a lot for the impressive work. And we're moving now to the second presentation. Professor Anat Rosenthal from the organizing committee. She's going to present mapping food security and diversity patterns among healthcare providers in 2 districts in Malawi.
Don't touch. Push the button.
It's true, but it's not me. Okay. So thank you for the presentation, and thank you, Victor. And I think, first of all, thank you for surviving the day and staying with us. And it seems, yes, definitely. And it seems like a lot of the presentations we had today sort of brought us here. So I'd be able to skip a lot of things and keep it short because we are already familiar with a lot of the things that are happening. And my talk today is part of a much larger project. Chacha mentioned it this morning, and then Moses has some interaction with it, and Moses' presentation, and definitely Dr. Henry's, and obviously the goats, they're always part of it too. But I want to shed light on the part of the project that was focused on health workers and talk about the impacts of the droughts on food security in the districts where we work, but mostly on health workers. So that's going to be the focus of our presentation today. And I want to start by saying thank you, and Shahal did it this morning, but nothing would have been possible without a group of incredible people, not just in Israel and Malawi, but mostly in Israel and Malawi supporting this work. So I want to acknowledge them and thank them again. And I'm going to go through what we're going to try and do today. I'm going to talk a little bit about background, but less than what I was hoping to do because you know all about it, and then talk about the objectives of the study, some of the methods we use for this part of the study, and then key findings and conclusions and things that we would love to think about together at the end of the presentation. And one amazing benefit of getting older is spending many years in the same place and seeing changes, and seeing the season changes, and seeing the harvests. And this is the agricultural area, the maize garden between the guest house in Neno district and the office and the hospital. And I walk through there multiple times a year for many years now, and I get to see different seasons and different crops, and the maize crops in different seasons. And this picture was taken at the same place, but in different years. So in a good year and in a bad year, in a year when there was rain and in a year when there was drought. And I think that was for us the starting point to start talking about how the droughts and severe climate events are impacting the lives of the people we work with. So not just the people that Victor just called our beneficiaries, but our colleagues and the friends we work with within the healthcare system. So this was the starting point for us. And there are a lot of studies about health inequalities in health systems. This is not new. They've been conducted all over the world. They usually talk about the differences between, the highly trained, highly paid healthcare professionals, the differences between physicians and nurses, and other employees of the healthcare system. A lot of these studies are being conducted in the global north. We know many of them. And there are even studies talking about emergencies and their impact on healthcare professionals, from the physical impact on healthcare professionals mental health of healthcare professionals. But for many years, they were in the realm of the people who study healthcare providers and not necessarily discussed publicly. And I think, and this goes back, Linda, to what you said this morning about COVID. And I think COVID made a huge difference in how we think and talk about healthcare workers in public conversations or in public discourse, not just in public health or in science. But the COVID pandemic was a game changer in terms of thinking and talking about healthcare workers and their role in the system. And there's a lot more focus on healthcare workers since the COVID-19 pandemic. And there were multiple studies conducting during the outbreak and after the outbreak about healthcare workers and their needs, the impact of the pandemic, both on their health outcomes, but also on mental health. And it was interesting because a few years before the COVID pandemic, there were multiple studies conducted with healthcare providers in West Africa who were part of the response to the Ebola outbreak. But these were they stayed under the radar. They weren't of interest to a lot of people. And the studies and the public discourse that came out of COVID was heartbreaking, but also productive, because these pictures that we saw of health workers wearing trash bags started a conversation about what do we need to address when we think about healthcare workers and how they're impacted by emergencies and by pandemic, to very interesting studies that were conducted related to healthcare workers and how they were impacted in very different places, one in the US and one in Mali, shed light on how these emergencies impacted mental health, but also how we can trace issues surrounding social inequalities, racism, history, into what the epidemic looked like in terms of healthcare providers. So for me, this was another lead into something that I would like to talk about when we look at the impact of severe climate events on healthcare workers. And so going into our study, one of the things that we were studying was food insecurities in the districts where we're working, and the impact of severe climate events and the droughts on food insecurity. But for us, it was also interesting to see or to explore food security and diversity among healthcare providers in the 2 climate-affected districts where we're working, and to identify factors that are contributing to food insecurity. So we wanted to see whether the healthcare providers that we were working with are also being impacted by food insecurity, and then what the patterns look like. And at the end of our presentation, I'll get to it, what could be done as we are working in the healthcare system. And so I'm going to skip that because we've done that many times today. We talked about Malawi. I think you know Malawi very well. You should all come with us. And I do want to say, so I'm not sure we talked about Chikwawa district. We spent a lot of time talking about Neno district today. But Chikwawa district has become our sister district, I suppose. And this is another district in the country that is severely impacted by climate events. And it was interesting to us because it is relatively close to Neno district where we're based. It's a much larger district. And for us, it was an opportunity to look at districts that were similar and different, but with a much larger population, not enough healthcare workers, but with a larger population of healthcare workers. And so we know Neno district. I have no idea what's going on here. I wanted to say a few words about the Malawian healthcare system. Dr. Henry presented the Malawian healthcare system this morning and talked about how it's a composite structure of health providers. There's the Ministry of Health that provides a regulatory infrastructure and basically runs the healthcare system, but healthcare services are provided by multiple actors. So there's the Ministry of Health, there's the CHAM, the Christian Health Association of Malawi, and there are also NGOs, and a small private system. So we're seeing a lot of actors within the healthcare system, and there's a major health workforce shortage in the country. And I know that this is true to any country you're going to visit. So in any country you go and you talk to people about the shortage, they're going to tell that it's a catastrophe in their country. I think the weirdest experience I had was being in a public health conference in Norway, which is when we teach about public health systems around the world, which is something I do this semester, we always talk about the Scandinavian countries as the places you would want to be. And then I go to a conference in Norway and everyone's complaining about the shortage. It's like, we're done. But in this case, we're talking about one of the countries that is suffering from one of the most severe shortages in workforce. And Dr. Henry mentioned this morning that one of the solutions was to push for more and more task shifting, to get other professionals into the healthcare system to redistribute the tasks and to train cadres of professionals who were clinical officers, health surveillance assistants, community health workers, attendants in the hospital. So reevaluate the tasks that the health system has and include more and more people into the healthcare system. In our context, this variation within the workforce created a system where these gaps that I mentioned between the different echelons of the healthcare system became even more evident. Because within the healthcare system, we're now looking at community health workers, who are people with primary, secondary education, who are also part of the system. Hospital attendants, cleaners, all these people are coming into the healthcare system and becoming part of the workforce, and a lot of them are based in the communities where they're working. So there are farmers from the communities where the healthcare center is. They're part of the community, not just part of the healthcare system. And that becomes an issue when we look at inequalities within the healthcare system. Because now within this system, we're not only looking at physicians and nurses and clinical officers, we're also thinking about community health workers and health surveillance assistants and hospital attendants. They're all part of the same healthcare system. And so I'm not going to repeat the conversation about the El Nino impact and I feel like we've been doing it all day. So I'm going to skip that and just remind you, there was a big storm, and then there was another one, and then there was another one, and then there was a big drought. And obviously, when we went back, and this is the part of the study that was, can you read any of it? Okay. So this part of the study was a mixed method study. We collected data in the two districts, in Neno and Chihuahua district. We did that between March and April and August and September 2024. And the reason we split data collection is because we wanted to go into the communities and the healthcare system in the rainy season and then go again in the dry season. And so March, April is sort of the tail end of the rainy season. And I don't know if I can say that we were lucky, because luck had nothing to do with it. But we had to delay field work because of the war in Israel, and the rain started late in Malawi. And so somehow we still aligned with the rainy season. We were planning to go in January, ended up going in March, and it was still the tail end of the rainy season. And then August and September is the dry season. We conducted surveys, both in communities, because we wanted to be able to look at food insecurities in the community and then in the healthcare system. And so we conducted 517 household surveys in rural communities, and that's where the rule "no canoes, no crocodiles" was initiated, because some of our communities were so remote that we needed to cross rivers in order to get to them. And then we also conducted 146 surveys within the healthcare workers from the facilities in both districts. And this was interesting. There was no way to get a sample because the population is so small. So what we did is we invited everyone to participate. We went to the healthcare centers with tablets and phones and pieces of paper, and basically we invited everyone who was willing to participate. We had the survey material in two languages, in English and in Chichewa, in the local language, and people could choose and either use their own devices or use our devices, or when Qualtrics was not working offline, use paper, which is something we had to do at some point. We also conducted 33 semi-structured interviews with health workers of all ranks. So there was different part of the study where there were household interviews on issues surrounding food insecurity, but for this section of the study, we wanted to talk to health workers. And by health workers, I mean the very broad definition of everyone who is employed within the health and welfare system, trying to understand both how they understood and viewed their recipients of services, their patients, but also what they had to say about their own experiences and their own household. And we also used food insecurity using the household food insecurity access scale, and food diversity using a 24 hours dietary recall. They had to answer in the survey what they ate in the last 24 hours, the different food groups. And obviously, analysis and ethics, trying to look at both the qualitative and the quantitative data that we had and see what came out. And we had some very interesting results, so kind of key findings. And I first, so obviously I'm an anthropologist. So full disclosure, I'm an anthropologist. But I came to acknowledge that the numbers are interesting and important. Don't love doing them, But I do, under people here, you should see your faces because it's like the anthropologists are laughing, the epidemiologists are laughing. But the point is that coming to acknowledge that we actually can look at the qualitative and quantitative data and get a big picture from the qualitative data to understand what we're seeing, and then dive in through the interviews and understand how people explain the data that we were seeing. And not surprisingly, we did find food insecurity within the communities. We were not surprised. What surprised us and saddened us, although maybe it shouldn't have surprised us, is the fact that we found food insecurity in the health workforce as well. Lower than the general population, but still we found that they were doing significantly better in terms of nutrition than community members, but they still showed concern concerning food insecurity levels. So this is not what we expected to find, considering, first of all, these are all people who had paying jobs, unlike a lot of people in their communities. So they were employed by the healthcare system. They had access to their salaries, to cash, to services at the hospital. We also found that support staff, so the lower echelons of the healthcare system, the health surveillance assistants, the community health work, and hospital attendants, suffered from more severe food insecurity compared to the clinical staff during climate crisis. And we talked to them in a year that was a drought year. So wherever you went, people were talking about the fact that there are no rains and that the crops are dying. And everyone was constantly measuring how much they were able to produce this year and trying to predict if they're going to have enough food to survive for the next season. We also found that gender was an additional risk, and people who reported poor reporting of health. So people who were already vulnerable were obviously more vulnerable to health insecurity. And so we wanted to understand the patterns. We wanted to understand what's going on. And so we dived into the interview, and few things that came up were sort of, we are part of the community. So when we're talking about food insecurity in the community, we're talking about us. We can't really distinguish between the community, the health workers and the communities that we're working with. And some of it was sort of blank statements that to anyone in the district were pretty obvious. We talked to so DODMA is the Department of Disaster Management in Malawi. It's the national department. We talked to the DODMA officer in Neno district, and the first comment was, my definition of food insecurity, the whole of Neno. So the entire district suffered from food insecurity. That's the starting point. And we are having problem to be food secure. There are communities that have always been food insecure and that do not have food that can last maybe 6 months from the day of the harvest. Others do harvest something, but they can just last maybe a month. So food insecurity runs through the life of the community constantly, and it gets worse with drought years. And health workers saw themselves, introduced themselves as part of the community. We live in our community. We live like our community members. So if everyone is affected, we are affected as well. And people talk about, even if they are originally from outside the district and they came to live in the district when they got their job, they are now members of the district. Their practices are similar in terms of agricultural practices. So they were not more or less ready. One of the most common topic of conversation in the drought year was we all planted maize because that's what you plant. That's what everyone has. And so if maize is not growing, then no one has food. So a lot of conversation about diversity, but the fact was that health workers were similar to everyone else in the community. And then the second aspect that came up very strongly was the need to support the supporters. And so health workers found themselves, this is terrible, health workers found themselves sort of stuck in between. And they've said, so a hospital attendant said, if we take that side concerning food, then it's a very big problem. It does not matter whether you are working or not, because the food is scarce, plus the prices have gone up. So a village like this one, where he lives and works, in the past, it was not everyone who managed or depended on their work, but rather they could go and cultivate. So right now, there is nowhere to cultivate, so we are experiencing a lot of problems. So even if you have a patch of land that is yours, and even if you have a salary to buy seeds, you can't cultivate. So you're going to be in the same spot as everyone else in your community. But also the question of what do we do to support the supporter came up, or the need to support the healthcare workers. And I think one key part would be, how do we put up the systems that can support the supporters. Most of the time, that is silent. It doesn't come out as clearly as it is. So that there is silencing around the needs of health workers because everyone is focused on the needs of the patients, of the rural populations that the health system is serving. And obviously, they are in dire needs. But if we distinguish between the health workers and the community, we sort of leave out the fact that a lot of the members of the healthcare system are actually part of the communities and suffering from the same issues. And so to conclude before everyone falls asleep, or is it making you hungry? All these conversations about food insecurity is making people hungry. I know how that works. And so one very interesting point that was important to us was to acknowledge that climate-related shocks affect not only members of rural communities, but also the healthcare workforce that is assigned to their care. This is something that we need to remember. And in settings where most households experience severe food insecurity, integrated support strategies must extend to health workers as well. So we should not distinguish between the health workforce and people living in the community. And then there's much like in the community, there is uneven distribution of food insecurity. So we know that in rural communities, we can identify and address vulnerabilities that predated the drought or the disaster and know that these people are going to be more vulnerable. We should actually do the same within the healthcare worker. And identify vulnerabilities. It could be gender, it could be the level of employment and the role, and target people that we know would need more support. And just for us, in terms of thinking and integrating these lessons within the healthcare system, the question is, what could we do within the healthcare system to support our employees that are also impacted by food insecurity? Thinking about diversity and access within the workforce, thinking about, lunches at the hospital, right? Thinking about how do we support the people we expect to support the communities. So this is the next stage for us, is to work with these data and then integrate it into programming and see how we can support staff and our colleagues as we're all going through these rough periods. So develop workplace nutrition interventions that are going to be effective and acceptable within the healthcare system and become part of the responsibility of the healthcare system. I'm going to stop here because there's more to come. And I want to thank our colleagues from Malawi who are part of this study and give the floor back to the next speaker. Thank you so much.
Thanks a lot, Anat. Indeed, it's very complimentary, all of this. Probably it's not a coincidence. So we're moving to our third speaker. Professor George Ogendi is from Egerton University, Kenya. He's going to present us now about water. It's also needed characterization of microbiological water quality and prevalence of waterborne diseases. Thanks a lot.
Thank you, and I want to thank the immediate speaker who has just finished presenting about the need for supporting healthcare workers in Malawi. And sometimes we support others, we get to a point where we forget about ourselves. So it's really a good thing that we should be supporting such kind of a workforce that is also making a contribution in helping those that are in need in those countries. So let me take this opportunity to welcome you to this presentation at this late hour. So if you have not slept up to now, you will not sleep during this presentation. And therefore, I'll take you through a quick overview of water quality issues, and related to that is the prevalence of disease in some of these areas. This is work that is coming as a result of some research that we did with my colleagues, Mercy Osiemo, as well as Professor Merimba. Both are from Egerton University, two different departments, and then there is also the component of the Dryland Research Training and Ecotourism Center. This is ideally what you could expect to see in most of these countries that are developing, especially in terms of access to water. This is the situation which has been up to now. We are talking about increasing access to water and sanitation, which is Sustainable Development Goal number 6, but we are not yet there, especially as a continent or as developing nations. And with it is that you are likely to see communities, you are likely to see many people accessing or using an improved water sources. They're just going to pick their water from a running river or some pond around or a reservoir, and they are going to be using that water for drinking, for washing, for cooking and all that. And as a result, you are likely to see microbial contamination being a cause of the water-related diseases in most of these areas. And therefore, we see nearly about 1.7 billion people worldwide being victims of use of that contaminated water. And this is the scenario in most of the areas, but this one here, the photo to the bottom right corner, was taken from the study area. And this is just from a river that is draining, and the others you can see, there are photos where people are really collecting water from an improved sources of water. And because of this particular aspect, the fact that you have contaminated water being used by this large population of people, the likelihood is that you have diseases like dysentery, cholera, and diarrhea being very prevalent in those communities. And you will continue seeing more and more people dying, approximately 1.6 million people dying globally because of such kind of contamination. You have cases of up to 4 billion, which tells you that it's so many. And sub-Saharan Africa, where of course Kenya happens to be, is among those that are most affected because of the lack of safe drinking water access in these regions. In this area, the study area, we have about 75 or 77% of the communities using an improved water sources. And remember, this is a community that is within an arid and semi-arid environment. And largely, the sources of water are from the running rivers that are also happen to be intermittent or perennial rivers, also shallow wells, and also in some cases boreholes. And because of the lack of piped water and poor handling water practices within those households, you are likely to see an increase in prevalence of those diseases. So, when you look at worldwide in terms of access to water, that is improved access, or those without access to improved water, improved sanitation, and the number of deaths, you'll see a very strong correlation there. I'm not able to, the pointer is, you can see, yes. So, the green one, which is access to improved, or without access to improved sanitation, you can see it, especially within the sub-Saharan Africa, is more or less the tallest. The same for water, you find that the percent without access to water is also very high, and therefore the number of deaths, especially measured as per 1,000, it's also on the increase. The same here, when you look at percent that is not served by potable water, 31%. Those that are served by a household connection, that is a yard tap within around the compound, you have 43%. And then you have a public tap that is 21%. Most important for us is the worry that there are those that are not that are unserved, which means they are going to be drawing water from those contaminated areas like this. And this is what you are likely to be seeing, that more of the communities in these arid and semi-arid environments, they are going to be depending on water from some of these reservoirs that have been built. They are not protected, and therefore access, especially for livestock, is there, and the people that are in that area, they are also using water from the same sources. And therefore the objective of this, or the objectives for this study, are to look at access, especially the sources of water. We look at the management practices, the occurrence, especially of those microorganisms that are indicators of contamination, and of course characterize the prevalence of those diseases. And of course the argument here is we are justifying the study based on SDG number 3 for good health and well-being, and number 6 that we want to see an increase in water and sanitation in these areas. In addition, it is within the African Agenda 2063 that we increase access to water for most of those communities in these countries. And therefore, the theoretical framework of this particular study was guided by the health belief model, in which case anybody that feels like they are sick, they are likely to go to the hospital. And also the reality that if you find that water is contaminated, you are likely to go and do something about it if you know that it's likely to affect your health. Charles Darwin, this is a quote from him. One of the things he says is that if the misery of our poor can be caused not by the laws of nature, but by our institutions, great is our sin. And this is very true, that sometimes we are able to do something about our problems, but we ignore them, we focus less on them, we prioritize less on them, and especially water and sanitation issues. This is the area that we did our study, and somewhere in the north rift of Kenya, that is the region where this study was conducted. And the research design was cross-sectional, besides, of course, mixed methods, because we took samples and measured the concentrations of those microbes in the lab. And the water samples were collected and, of course, processed as per the US EPA guidelines, as well as the CAST, that is Center for Affordable Water and Sanitation and Technology 2013. And they were processed, and of course we measured the concentrations of those microorganisms. We took samples from boreholes, the top left and to the top right, then from shallow wells, the bottom left, and to the bottom right from the rivers that were passing, or a river that was passing by. Those were our sampling sites. The samples were processed using the most probable number, especially for microorganisms, as well as the total bacteria counts using these colony forming units method. This is in the lab, how they were processed and, of course, enumerated. And the results indicate that water sources, of course, in this study area, 74% of the people here drew their water from the river Pekera. That's a local river that is around there. And 75% of them, again, they walked a distance of over 150 meters to the point of water collection. And 32% of the respondents, they covered that long distance that we are able to see over here. Now, to us also important is that the majority from borehole and the river, and of course, fewer were from the water pans, and of course, very few, of course, getting water from the tap. The distances are shown there, and then finally, the time that is taken to fetch water from these areas is indicated here. Now, in a nutshell, most of these variables that we consider when it comes to measurement of access to water, they were all violated, meaning that these people have inadequate access to water, especially when you're looking at the various variables. Now, the time and distance, this is what I've just talked about. Then there were these wash characteristics, household frequency of cleaning containers. This is especially handling of water, sanitation facility, whether it's present or not. We had about 70% having pit latrines, but some are using a bush, which is, of course, likely to be open defecation and therefore likely to contaminate the water sources or drinking water sources. The distance to the facility, that is to the sanitation facility, is relatively, in most of the cases, over 10 meters. And then the household water collection and storage facilities, most of them, they were falling in the range of the 20 to less than 20 liters per household. Now, according to our assessment, the reality is that there is inadequate access to water, including inadequate water storage containers and also improper water or drinking water handling that increases microbial contamination. With respect to the concentration of microbes, from the water source from the river had the highest, especially during the dry season. During the wet season, it was more from the boreholes and from the wells. And then when you look at the concentration of the microbes at source, that was at the point of use, that is within the households. And when you're looking at the concentration of microbes in the dry season at source, they were relatively higher in the borehole and the river. And also in the wet season, they were in the river more than the other side, drinking water sources. In terms of preference or prevalence of these diseases, we had typhoid being the top, followed by diarrhea, and then, of course, other skin infections, especially during the dry season. And then we have more of these diseases, of course, again, diarrhea topping, followed by typhoid during the wet season. In conclusion, what we find or what we found out is that all these households in this region, the distances that they have to go or to walk before they get to where the water sources are, it's much longer, the time is longer, and more than half of them, or about half of them, practice open defecation, which are likely also to affect the community in terms of contamination of water, and which also ends up affecting their health. There were high concentrations of total coliform and the E. coli, which of course tells you that that water, because the drinking water quality guideline is 0 E. coli, 0 TC, and that means that all these water violated the World Health Organization drinking water quality guidelines. And finally here, the clinical records also that were reviewed from this area demonstrate that indeed there is a linkage between the disease and the quality of the water that is being used. In recommendation, we had a number of them, but safe potable water sources should be provided, and you'll see soon how we have intervened. And then handling practices, including the kinds of storage containers, the use of chlorine, especially for disinfection of the water, active community participation, especially in enhancing awareness about use of contaminated water. So, which means public health programs are key, and of course, developing local level action platforms to help in preventing water-related programs. In schools, the WASH program is being implemented, and especially including having toilets for each one of these households, and then regular monitoring of water quality in those areas. Since the end of this project, we have also now had some of the reservoirs being done in those areas, water being pumped to elevated water tanks, and then the water, especially using solar power or solar panels, and then distributing water that has been treated to those communities in those areas. And in some cases or some areas, we have done wells, that is boreholes, which are now protected and at least can provide better water to these communities. In acknowledging, we have IGAD, the Intergovernmental Authority on Development, the UNDP, the county government of Baringo, as well as Egerton University and the Global Environment Facility, and Kenya Organic Agriculture Network as being the support team that played a role in this research and development. Thank you.
Thanks a lot for this important presentation and the excellent work. So there was a bit of a change in the program, and we are now having Professor Julianne Meisner at University of Washington. She taught me that it's a UW. And the presentation is a One Health approach, I would say a relational One Health approach to social and ecological change in Mongolia, Brazil, and Kenya. Julianne just arrived in about a 24 hours delay. So thank you so much for going all the way to be with us. It's a... I think, Julianne, that because of the change, so it's probably in the other room, we're not to all the way. So what I suggest, if that's okay, to maybe we have one recorded presentation. No. No, but Meanwhile, I just want to say that we have, some of us have an amazing project with Julianne on brucellosis. And I had the privilege to visit UW just about a month ago. Wow, so it's 2 months ago, but who's counting? And Julian, this is your second visit, third visit in Israel? Wow. I'm not focused. It's too late. And the concept of relational One Health emerged while we were doing some work together. And I think, Anat, you raised it first, the copyrights, but it has already quite a lot of citations. I can also start singing, maybe. What do you think? I'm so sorry, Julian. It was our mistake because we changed without bringing it here. We want to keep you awake. We want to keep you awake for the jet lag.
I know. Yes. You can, grant up the theory I have for Delta Airlines right now, so that'll keep me awake. So we'll pull it up. DDD Meisner. There you go. Yeah. Work your magic. That'd be great. Yeah.
Great.
Thanks, Nadav. You'd be a great opener. Yeah, we have a lot of institutions. That's it, yeah. When does it start it? Okay. Yeah, a success in the end. So yeah, as Nadav said, I'm just off of a plane from JFK. So I might not always successfully string words and ideas together in this moment, but I will do my best. So yeah, I'm kind of taking, as I was displaced or loaned or welcomed into a different session than the one I was scheduled for. So this isn't really about food, but it's a pretty high level sort of, I guess, discussion of my thoughts around rural communities and the transitions that they're facing and how that interfaces with health, with some examples from Mongolia, Brazil, and we'll be back in Kenya as well, but a different county this time. So rural communities throughout the world, and this is high-income countries, middle-income countries, low-income countries. It's literally every place in the world that has rural communities. So perhaps not Monaco and Andorra and things, but pretty much everywhere else. There are fundamental transitions going on for these communities. There's large-scale ecosystem destruction, deforestation example here, which there's different drivers for that, but in many places is to support plantation forests, mineral extraction, increasing urban expansion of the urban frontier, and commercial agriculture. And in many places in the world, this is facilitated by large-scale land acquisitions, land concessions, what many term the global land rush that really kicked off after the 2007-2008 financial collapse. And this is often by multinational firms. And then this is compounded by the effects of climate change, which in the drylands is often increasing heat, decreasing precipitation, and then heavy rainfall is leading to floods and resulting disease transmission. We also have an agricultural transition going on from subsistence agricultural systems to that were typically polycultures or multicultures to large monocultures destined for export markets, which is related to a fundamental change in livelihoods from subsistence-based livelihoods to wage-based livelihoods, often in precarious and informal labor markets, which are often all the more precarious for women. And then we have a aging and declining rural society as young people move to cities and towns for education, for jobs, and then are unable or unwilling to move back to where they came from. And these transitions, which are economic, they're environmental, they're social, have really profound implications for the health of human beings, but also other animals and the other biotic and abiotic beings that share our planet. So we really need to take a One Health approach when we think about, what are the health implications of these transitions that are happening for rural communities throughout the world. And I think everybody in here is familiar with One Health. This is sort of the canonical One Health triad, where you've got three circles. You've got human health, animal health, and environmental health. And it's been a really, really powerful tool for communicating what One Health is, and it was really revolutionary when it was first introduced. But there have been more and more criticisms of this framework as limited, and as Nadav said, we proposed a revision to this. But these criticisms aren't just coming from us. So I've summarized here what I think of as the main criticisms, not just my own, but what I see in the literature. And the first is, why do we do this? We are animals, right? So why do we put humans in one circle and animals in another circle? The second, what do we mean by environmental health? What is environmental health? Do we mean like built environment? Do we mean air pollution? Do we mean healthy water? Or do we mean things like endangered species and biodiversity and conservation? Is the health of the environment, or the environment as a public health issue, a potential threat to human health? And if we mean the health of the environment itself, then humans and other animals are also part of that environment, right? We exist within ecosystems, and we are keystone species in many ecosystems, of course. The third criticism is not of this figure, but of the way that One Health has been implemented, which is the criticism of biomedical reductionism. That One Health, just because of pragmatic decisions, has largely gravitated towards zoonoses and antimicrobial resistance, and has really not dealt sufficiently with the other health threats that really exist across multiple species. And related to that has been really focused on the proximal determinants of health. So zoonoses, AMR, but thinking about things like, do people co-house with their livestock? Do they wash their hands? Do they eat wild animal meat and things like that? And not really thinking upstream enough to the larger contexts that really shape the way that humans interact with the other species that we share our planet with. So together with, sorry, I abbreviated it, but Anat Rosenthal and Nadav Davidovitch, as well as Barak Hermesh, and other colleagues from the US and colleagues from Brazil as well, proposed a new way to think about One Health that we termed relational One Health. That you can see up here, we've nested humans within other animals, and they both nest within ecosystems. And all of these humans, animals, and ecosystems are health bearers. So health is a distribution over all of these beings, meaning that if the ecosystem is not healthy, then the humans that exist within that ecosystem cannot be healthy. So everything nests, and there's fluidity there. And then the environment is shared by all of these health bearers, and it certainly has biological and physical properties, but it also has social dimensions, cultural dimensions, economic, political, and historical dimensions. And then these health bearers interface with that shared environment through a process called embodiment, that's not our term. That comes from Nancy Krieger's Ecosocial Theory of Disease Distribution. So I'm going to, through some case studies from Brazil, Mongolia, and Kenya, talk about some examples of how I put relational One Health into practice. And then I'll wrap up. So the study in Brazil, before I talk about what we did, I want to motivate it a little bit with some background. So I'm showing a relationship to you here that if I were to present this in a One Health conference, everybody would agree with me, and there would be there would be no pushback. Everybody kind of accepts this fact that harmful land use changes are really the fundamental driver of the emergence of pathogens that can cause pandemics. And then obviously there's a feedback with climate change there, where when you have, when we're doing things like cutting down forests, whatever ecological consequences come from the deforestation are worsened by things like wildfire, heat, and so on. But I've left this large white space here because what's missing is what's upstream of harmful land use changes. Harmful land use change does not happen randomly. It happens because agents in control of land decide to enact those land use changes. And I've simplified that as calling it land tenure. Land tenure are the systems that determine how land is owned, transferred, or used. And I've been trying for a couple years now to convince public health to be thinking more about land rights and land tenure systems. So we published this back in 2022. And then this led us to a pilot project in the Midwest of Brazil in a quilombola community. So quilombos are communities that were established by people who escaped slavery into Brazil's regional biomes, the Pantanal, the Cerrado, and the Amazon, and they brought their agricultural knowledge and sort of harmonized it with the ecological knowledge of indigenous communities that lived in those biomes and peacefully coexisted for centuries. And this is a display from a community workshop that we held. So this community for research, for compensation for participation in research, they did not want individual level participation because that would create kind of haves and have-nots of who participated and who did not. So they asked for community level compensation in the form of workshops and topics that they chose. So this was a workshop by a Brazilian lawyer with expertise in quilombola rights, and so he flew in from Sao Paulo and gave a workshop on rights and opportunities for solidarity. But I'm showing you this because you can see here, even though this community, these people, they've been separated from their West African ancestry from their West African ancestry for centuries. That heritage is still extremely important to them. And so there's a lot of sort of symbols of, spiritual traditions that come from West Africa that are still very important to the quilombolas in Brazil. This is Angola Janga, which is a graphic novel about Palmares. Palmares was a community of quilombos that fought off the Portuguese army for almost 100 years, about 20,000 quilombos, and it was from 1605 to 1700, I think, that they managed to keep the Portuguese army, at bay. And then this is Beatriz Nascimento, who's was a quilombola poet, historian, and leader of the Black Rights Movement in Brazil until she was murdered in the 90s. So I'm showing you this here to kind of talk to you a little bit about who quilombolas are and how important they are to the social fabric of Brazil. So our project, framed in terms of relational One Health, asserts that quilombola land control, which itself has political and historical antecedents, including the history of emancipation and rural settlement, is really a fundamental driver of ecosystem preservation. And I'll talk about why that is and what we found there in a little bit. And that has social and economic determinants, including economic vulnerability and different dimensions of racism. And that leads to or really influences the capacity of the ecosystem to maintain insect vectors for diseases. So the framework I showed you, and apologies, my train of thought has been disconnected, so I forgot to tell you this piece. We wrote this, and we've been sort of advocating for this in the context of pandemics, that land rights are really important to think about how do we prevent pandemics. But because pandemic emergence happens quite rarely, or we only detect it rarely, we are sort of using arboviruses as a test case for this, because arboviruses, things like dengue, chikungunya, West Nile, Oropouche, there's quite a high burden, so statistically it's easy to detect. And also insect vectors are very, very sensitive to changes in the environment that happen over small scales in terms of space and time. So yeah, we're in terms of relational One Health, we're asserting that land control, quilombola land control, is really critical for preserving the ecosystems in which quilombola communities live. and that this in turn results or causes changes to the vectorial capacity of those ecosystems, resulting in conditions that can favor or disfavor arbovirus transmission. So we conducted a pilot study in the community of Matacavala, the picture I showed you there on the left, to characterize this relationship here. How does the Quilombola community having control of their land influence the health of the ecosystem in which they reside? And so this is just to summarize our results briefly. We found this is a picture of an agroecological plantation in a part of the territory in which the Quilombola community has retained control. You can see this is a mixture of vegetation native to the Cerrado alongside of crops that have been planted. And right here is a piece of land that, while it has the same official titling status as this piece of land, which is an insecure land tenure situation, someone from outside of the Quilombola community drove a heavy machinery into a piece of land that used to look like this to find gold. There's a lot of gold in this region. And so really destroyed the agroecological plantation that had been there. So we have this threat from outside of the community of people digging, coming into the community to find gold. There's expansion of cattle and soy plantations as well. But inside of the community, there's also expropriation of land that occurs through a predatory legal practice. So Brazil has this system, the Rural Environmental Registry, or it's CAR in the Portuguese acronym, and the CAR within Quilombola communities must be registered collectively, but landless families who have come into the community and were welcomed by Quilombolas in the 90s, being told that this would strengthen their claims to the land, and it was really a solid goal of solidarity, found that landless families were actually illegally registering tracts of land as individually owned, which then makes it very difficult for Quilombolas to secure a title, because when they go through the titling process, owners of these plots of land must leave the territory and be compensated for doing that. So they have not been able to secure a title of their land, in large part because of this system here. So the blue circles are non-Quilombola households, and then the red and pink are Quilombola. So as I said, we looked at these two parts using qualitative methods. I didn't really get into what we did here because I'm keeping this pretty high level, but the paper is here if you want to read more about it. And then in the next phase of our work, we're going to be using quantitative methods to bring the whole thing together, really bring in the mosquito testing and arbovirus testing as well. So I'm switching gears now, and I'm going to talk about Kenya briefly before I talk very, very briefly about Mongolia. So we are in Marsabit County, which is also a dryland region within Kenya. It's the area outlined in black here. And this is a community in which rainfall is too unpredictable for people to really rely on crop agriculture. So there is a very, traditionally people have relied on livestock agriculture. And they've also required mobility. So in order to maintain their livestock herds, because of the unpredictability of water and pasture, people have to move over the landscape seasonally and between seasons with their animals. And Marsabit, like many other pastoralist settings, is facing a confluence of challenges, with the first one being climate change. Kenya experienced its most severe drought on record from 2020 to 2023, when I think 6.4 million people required humanitarian assistance and almost 3 million livestock were documented to perish. And related to climate change, there's also a significant problem with violent conflict, which is often in the form of livestock raids. And this is a chart of conflicts involving pastoralists by month in Marsabit and neighboring counties, showing you the relationship between these conflicts and climate change. So these bars, which were supposed to be orange, is the dry season, and then the red is the drought. And this is a significant underestimate. This is, let's see, that's around the end, that's 2023, so this must be towards the end of 2022. It looks like it's about 19 or so conflicts in Marsabit, and then the counties that surround it. There was a lot more than that. This was a daily occurrence in Marsabit alone. So really, really significant underestimation, but you can still see the relationship here between climate change and conflict. And then livestock diseases. We talk a lot about health disparities in humans, and we tend to assume that we kind of neglect veterinary services when we talk about that. We kind of act like it's not a thing because we don't talk about the socioeconomic status of animals. But domestic animals absolutely do have and are affected by the socioeconomic status of the people that own them. You know, the ability of someone to provide care for their pet and the healthcare that pet receives is very much determined by the conditions that person lives in. And so it's really hard to find good data on disparities in the provision of veterinary services. But Marsabit County, despite owning, or the pastoralist county, I think Marsabit County specifically, I can't see my notes here, so I forget the numbers, but has less than 2% of registered veterinary drug shops in Kenya are in Marsabit, despite containing, I think it's like over 20% of the national herd. So a significant disparity there. And then this is a picture that I took during the drought. And these are goats that had died. I think that one's actually still alive, but was going to die very soon, with a bottle of tetracycline in the foreground, because these goats had most likely died of toxicity. So when there's not enough browse, they're going to be less discerning and eat things they shouldn't eat, and then you get mass toxicity problems. But the person caring for them saw that they were starting to get sick, grabbed what he was able to grab, which was an antibiotic. Of course, it didn't help them. So you have this sort of confluence of, we have an inappropriate use of an antimicrobial as well. And then land dispossession. So similar to Brazil, where we see land dispossession for from outside and within the community for agriculture, for mining, and for other aims. In northern Kenya, a major form of land dispossession is green energy infrastructure and conservation, which can be controversial because we're used to thinking of green energy and wildlife conservation as fundamentally good things. And of course, it is important to reduce our dependence on fossil fuels, and it is important to safeguard our ecosystems. But we need to be thinking critically about, when we do those things, whose land is that happening on, and who is being dispossessed in order to produce renewable energy for us, because this energy is not going to people in Marsabit. It's going straight to Nairobi. So this is the Lake Turkana wind farm, which was built in 2014. I think construction had finished in 2014, and then in 2017. It was the Kenyan courts decided that the Rendile community, who this is their ancestral land, was not properly consulted. The requirements for free, prior, and informed consent that's afforded to indigenous people was not observed, and that the land had been taken illegally. But at that point, the wind farm had been built, and there wasn't really much that could be done about it. And then this is an interesting analysis by the Oakland Institute on conservancies in this region as well. So we did a pilot study around the same time that we were working in Brazil to kind of just get to look at what are the health impacts of these land changes that are going on in Marsabit. How do they relate to each other? What's important here? And we discovered that in contrast to Brazil, am I going over time, Nadav? 5 minutes, okay. Mongolia short. That in contrast to Brazil, where securing a land title is very, very, very important to the community of Matacavallo, folks in Marsabit kind of were like, I don't really see the point in that. The land is large, they use it at different seasons, it's viewed communally. The importance of having this piece of paper didn't really resonate with people. But the consequences of no longer having access to the land that they need, that did resonate with people. So here we're calling that large-scale land acquisitions, largely for infrastructure projects and conservation. What we observed from our results is that these large-scale land acquisitions and climate change really come together to drive violent conflict, which of course has social dimensions as well. And we're theorizing that can actually influence the transmission of diseases between animals and humans. And I'll detail why we think that's the case in a minute. And we, much like our project here with the Bedouin community, we propose using networks as sensors of this change. So networks are used by epidemiologists to study disease transmission. They're also heavily used by social scientists to study the transmission and evolution of social processes. So our idea is we can really use networks as a methodological bridge between those types of research questions. So we used We're also using livestock geotagging. We're not doing that here for obvious reasons, but using livestock geotagging as a tool to construct livestock contacts for a contact network. And that brings me to Mongolia, because in Mongolia, we are really focused on developing methods for measuring and modeling human livestock contact networks. So this is an NIH grant. And this grant isn't really, it's really on methods development. It's not really on hypothesis testing, but Anat encouraged me to think about it in that way for this presentation. So I kind of, I'll come back to that in a second. So I kind of on the fly decided to think about what we've been seeing in Mongolia and bring it into relational One Health. So I put this together on the plane. So it needs some more maturity. But what we're seeing is, again, a declining and aging rural population. What you have very small household sizes now. It's often 2 elderly adults with maybe 1 adult child, and everybody else is in the town. Also a declining birth rate. And then we've got climate change and overgrazing. So we've got causing significant degradation to the grasslands. Mongolia is a unique situation where, because of the cashmere industry, there has been a dramatic increase in the national goat herd, increased fivefold in 10 years alone from the end of the 90s to the 2000s. But there was a recent analysis, a lot of the grassland degradation has been blamed on overgrazing, but a recent analysis using causal inference methods pointed to that, yes, this is a problem, but it's really dwarfed by climate change. So climate change is really the main culprit here. And what that's causing, and this has created some problems for us where we've had to revise our protocols, because we're finding that people are settling much further apart than they used to, because they need a lot more land to graze their animals over than they used to need. So there's a much bigger space that they're moving over. And so my thought was, so that is probably fragmenting social support, because you have people spread over a much larger area. So in network terms, we have a reduced clustering in the network, but it's also meaning that animals are coming into contact with animals from more other households than they used to, because you don't have these tight clusters anymore. You have a network that is the longest string in a network that can connect one circle to the others is a lot longer than it used to be. So you have reduced social support, and you also have increased disease transmission. So bringing this more concretely into networks and bringing it back to Kenya. So again, in Mongolia, we're working on how do we actually measure and model networks that include animals and humans, and then bringing that into how we test a hypothesis. And in terms of this framework here, what we've got here in panel A is what I call an unperturbed network. So this is a network exhibiting community structure. The colors are different communities, and then the circles are people or animals, and the lines are connections between them. B, this is what happens when you have resource scarcity, and that resource scarcity could be because of climate change, droughts, and other manifestations of climate change, or because of large-scale land acquisition. So people can no longer migrate over the territory they would migrate through because there's now a solar farm or a wind farm or a conservancy they can't move through, or a large road. And so you have more people congregating around fewer, and animals congregating around fewer water and pasture points. C, this is the aftermath of a livestock raid, so that violent conflict piece here, where the animals that were, so the blue community has done a livestock raid on the orange community, and you have some orange animals mixed in here now with the blue people and animals, and whatever diseases those animals had are now going to be mixed in with these animals. And then this is a change in migration patterns to prevent violent conflict. So you have the green and the yellow community kind of coming together as allies, moving their animals together to prevent a raid that is coming from the blue or orange community. And so you can imagine, you can simulate in a computer, in a program, what if there was a disease in this animal? How fast would it move through the network when the network looks like this versus when it looks like this? And so that's a way that we can sort of bring these, transdisciplinary hypotheses together. So that's all that I had. And apologies for the somewhat disconnected train of thought, but happy to answer questions that you have. Yeah. Oh, right.
And now there is a recording. Unfortunately, Professor Stavros couldn't make it, so he sent his video.
Hello, and thank you for the invitation. So today, my goal is to present to you not so much on the temperature regulation and the heat, but rather on one of the most common implications of high environmental temperature, which is hydration. Did you know that hydration and fluid intake are the least studied topics in nutrition? And even though that more than 50% of our body weight is made out of water, which is roughly at least 35 liters for an average human being, a small decrease in water, like less than 1%, can decrease exercise performance. And we know that 10 to 15% of water loss, it's probably the range where people typically can die from dehydration. Most of what we know about hydration comes from old studies from exercise in a hot environment. And if you look at the historic progression of hydration science, we see that some of the first studies started in early 1910s, looking at the impact of dehydration on exercise performance. A few years later, a lot of research was concentrated on how bad it is to drink while you're exercising or being physically active. And after several years, back in 1980s, we figure out what are the mechanisms of dehydration and decrements of exercise performance. Believe it or not, it was not until 2004 that, at least in the United States, we had the first dietary guidelines for water intake that were published at the time at the Institute of Medicine, now known as National Academy of Medicine. And it wasn't until 2010 that we start seeing more and more data on how fluid intake and hydration overall impacts health. So the first question I would like to address today is, how much should we drink? So these are the dietary guidelines in the United States, and if you pay attention primarily on men and women, adult men and women, you will see that the total water intake is 3.7 liters and 2.7 liters for men and women, respectively. This is total water intake that includes not only what we drink, but also what we eat. So if we correct, based on the fact that about 80% of water intake comes from fluids, from liquids, that number is around 2 liters for women and 3 liters for men. And you can see approximately how many glasses per day. These numbers seems to be a little bit smaller in Europe, which is 2 liters for women and 2.5 liters for men. So the big question that I am often asked is, like, how much people really need, not how much they have to drink, but how much they do drink. So I purposefully picked two age groups that they seem to consume small amount of water. One of them is the older adults. These are data from the National Health and Nutrition Examination Survey from the United States. And we can see that more than 60% and 96% of men do not meet the dietary guidelines. And underneath you can see that the approximate deficit here, 2.5 cups for women and 5 cups per day below the dietary recommendations. So in children, the data are also not very good. You can see in different age groups. Here in the pie charts, you can see the percent of children that do not meet the dietary recommendations, the DRI, 75% in 4 to 8 years old, 83% for girls 9 to 13 years old, and 85% for boys 9 to 13. And in the bar chart, you can see from the red component of the bars, you can see the amount of fluid that the average value is below the dietary recommendations. So what happened with inadequate fluid intake? This is an interesting study that was published in 2012. They wanted to characterize the profile of what we call in the literature low drinkers, people that they chronically consume small amount of water. So they took 250 subjects. They selected specifically the 50 higher and 50 lowest drinkers, trying to compare people that they drink a lot of fluid every day and people that they drink small amount of fluids. And what they've noticed is that there were two main things interesting. The low drinkers had elevated arginine vasopressin, and they also have elevated cortisol, which I don't really have time today to cover both of them, so we'll concentrate primarily on arginine vasopressin. So are these people dehydrated? Some people are dehydrated and some people are probably chronically dehydrated. Like athletes could be, I would say, transiently dehydrated after workout, especially in a hot environment. Older adults, or a significant portion of the older adults, seems to be either transiently or chronically dehydrated because they have suppressed thirst. We know manual workers, especially when you work in the heat, and trust me, I live in Phoenix, one of the hottest places in the planet and the hottest city in America. When people work during the summer outdoors, they really get dehydrated. There is not any way you can drink enough to maintain hydration. And of course, there are a variety of medications that impact thirst, like the selective serotonin reuptake inhibitors, or it's a category of antidepressants, and the now super popular GLP-1 receptor agonists like Ozempic and the similar medication that suppress appetite and also suppresses thirst. So what happens during the day? Hopefully most people are within this, what I call the green zone, or the zone of euhydration, where you end up drinking a little bit and your total body water goes up, and then you forget to drink, or you're busy, or you're doing things and you lose some fluids, and your total body water declines. And maybe throughout the day at some point it might increases above what is optimal, and you go in the zone of overhydration. And let's say you have a task to complete outdoors, and you don't have fluids with you to drink enough, and you even dip a little bit in the zone of dehydration. However, there is this area, the yellow zone, which I have been using the term underhydration, where this is where most people tend to live. People that they are not consume adequate amount of fluid, they tend to live in the zone of underhydration. So what happens when you're in this zone, that during the day you might be within the normal euhydrated state, you end up spending a lot of time in the underhydration, and when you leave there, it's much easier to reach down into the zone of significant dehydration. So to describe a little bit this condition of underhydration, it is described by low water intake, so you are not drinking adequate amount of fluids. Total body water, it might be a little bit declined, but overall hasn't changed significantly. Thirst is not elevated, so you're not thirsty. Your plasma osmolality or plasma sodium is usually within the normal physiological range. But what we see elevated vasopressin, and we also see elevated urine biomarkers. In this case, I'm referring to urine osmolality or urine-specific gravity. So, what is the link between underhydration and health? We know, at least in the impact on kidney function, that low water intake is a significant risk factor for chronic kidney disease, kidney stones, etc. So, in the study from Australia, Giovanni Stripoli presented that the lowest risk for chronic kidney disease is associated with elevated, the highest level of fluid intake. Here it's close to 3 liters. And the reference value was the lowest group, that was about 1.7 liters per day. We also published a study looking at the risk of kidney stone calcium oxalate crystallization, so kidney stone formation in the kidney, and we found that the higher the urine osmolality, the more concentrated the urine is, the higher the risk for crystallization. And we also came up with some cutoff points that there were between 5 to 570 millimoles per kilogram of water for urine osmolality, indicating the high risk of crystallizing kidney stones. To be able to have this type of dilute urine with low urine osmolality, then it is required to drink adequate amount of fluids, to really drink as much as recommended from the dietary guidelines. In the area of glucose regulation and fluid intake, this is one of the first studies published almost 14 years ago, showing that low water intake was inversely and independently associated with the risk of developing hyperglycemia. French cohort, they took 3,600 middle-aged men and women, they followed them for 9 years, and they saw this negative impact of low water intake on glucose regulation. On a different study, the scientists look at the risk of not per se fluid intake, but rather the hormone that is regulated by fluid intake, which is called vasopressin. And instead of vasopressin, actually, they did measure copeptin, which is a surrogate marker for vasopressin, also known as antidiuretic hormone. So what they found was that high levels of copeptin, higher than 6 picomole per liter in women and higher than 10 picomole in men, was 3 to 4 times higher for risk of diabetes, which is a risk equally strong to the risk of obesity in the development of diabetes. So in my lab, we tried to study the acute impact of elevated vasopressin on glucose regulation. So we took healthy adult men and women, 60 of them, and we did this protocol of 2 hours, either isotonic, that was the control, or hypertonic saline infusion, and that increase in tonicity via hypertonic saline infusion increases the level of vasopressin. Followed this 2 hours, we did a 4 hours oral glucose tolerance test that you can see here. So our data indicated that when the subjects had elevated vasopressin, the glucose concentration was significantly higher compared to the isotonic or normal levels of plasma vasopressin. And also there was a small delay also in the increase of insulin. That was probably one of the reasons why plasma glucose was significantly higher with the high levels of vasopressin. We also use epidemiology, and we try to study the association of underhydration with obesity, chronic disease, and even death in the United States in a population 51 to 70 years old. And we use the enhanced data again, the National Health and Nutrition Examination Survey data, and we found a strong association not only with chronic disease, but also with life expectancy. Other people have also found similar impact of suboptimal hydration, that it seems to impact metabolism, degenerative disease, and also life expectancy. And this is a study published from the National Institute of Health and the United States, from the NHLBI Institute. And one interesting thing that they found in this study, which is something that we haven't seen from preliminary data, is that the suboptimal hydration seems to have one of the most significant impacts in disease like dementia and heart failure, that especially with dementia, we don't have that much data looking at this relationship. Again, from the same group, from the National Institute of Health, they found that middle-aged high normal sodium, so they use the levels of sodium as an index of hydration. And one interesting approach that they use, normal sodium actually, it's anywhere between 135 to 145 millimole per liter. So what they do within that normal level, they're taking the slightly elevated, anything above either 140 or 142 millimole, which is a response of suboptimal hydration. And they found that elevated serum sodium seems to be a risk for accelerated biological aging, chronic disease, and again, premature mortality. Again, more data also from the same group looking at the same biomarkers in relationship with heart failure, and showing that the highest levels of sodium are associated with a higher risk for heart failure. And again, the important thing to remember that this is within the normal level of plasma sodium. So these people are not by definition hypernatremic. They are not clinically dehydrated. They're people with normal plasma levels of sodium. However, because their plasma levels of sodium is slightly elevated, that seems to drive antidiuretic hormone, as you see here, and that antidiuretic hormone seems to be the culprit that is associated with all these negative health effects. So, in summary, I would like to state that underhydration, I think it's a relatively new concept that we have seen nowadays, is associated with inadequate fluid intake, unfortunately without any physiological signal of thirst. What we really see is that we don't go to the bathroom much, and when we go to the bathroom, our urine seems to look more like apple juice or orange juice and less than straw color or what I want to say, lemonade. And this is a list of several things that to be associated with chronic underhydration and elevated vasopressin, from the classic kidney disease, cardiovascular disease, diabetes, and also things that we were not thinking about it a few years ago, like dementia, and even mood, cognitive performance, and yes, it's not the typo, even social behavior. Unfortunately, I didn't have much time to really go into every single one of them in depth, but hopefully this will give us a little bit of an opportunity to open up this conversation. So before I close, I would like to give you a little tip of what you can do. And this is a study actually that we published in 2021, a few years ago, where we reanalyzed some of our existing databases from children and adults. And what we wanted to do, we tried to combine simple self-assessed biomarkers of hydration to be able to see whether, without really taking a blood sample or without really doing anything really invasive, whether you can self-assess your hydration level. So we combined two markers, two simple biomarkers. One is the urine color and the other one is the void numbers. So how dark is your urine and how often you go to the bathroom. This is a urine color scale, the original urine color scale developed by Larry Armstrong back in 1994. So what we found, at least for adults, we found that if your urine color is above color 3, so when it starts looking pretty dark, and if you're going under 7 times per day, then you're not well hydrated. Or if you look at it differently, if your urine is below 3, and if you're going at least 7 times per day to the bathroom, then you should feel pretty confident that you're adequately hydrated. So this 7 times per day, if you do the math, how many hours you're awake, pretty much it means whether you're going to the bathroom every 2 to 3 hours. So in closing, I would like to thank all the people that they do all this work in my laboratory at Arizona State University. And I would be happy to open to any questions. Thank you.
Thanks a lot, Stavros, for the fascinating lecture and very useful advice. I think that we are going to take now some questions for the presenters. Hi, Stavros.
Hello, good morning. Good afternoon.
Maybe a short question, how you relate all of this to climate change in terms of as someone who's actually living also in Phoenix or Arizona. So in terms of working with both healthy population but also patients.
Yes, Nadav, thank you for the invitation. I'm terribly sorry I could not make it this time. So so the recorded presentation, I guess, was the second best to that. The interesting thing when you live in a hot environment, and we also live in a desert like yourself, is that your needs for water are always higher. And the message that was trying to come across the presentation was, if we just rely on thirst, we're not drinking adequate amount of fluid. We're programmed to survive with very small amount of water, relatively small amount of water. And this is good if we're talking about for survival. So when you add the heat, that obviously increases the fluid needs because you sweat more, you lose more by respiration, both by respiratory water loss and by skin loss via sweating, then the importance of hydration comes to be much more significant for quality of life, well-being, and we have more and more data nowadays that they show that even life expectancy is affected by whether you're adequately hydrated or not. So it's very relevant to global warming and environmental temperatures and water availability, of course, which is a big issue for many countries. Even in the United States, actually, about 40% of the Native American lands do not have any running water, so they have to go and fetch the water to be able to drink.
This is, I think, an excellent connecting point to what we were listening also before, because we have, of course, the individual, but we have, as you just mentioned, and we also heard for some of the presenters, the question of access to water. We are here nearby the Bedouin community, many of them living in unrecognized villages with no access to water. And so it's clear that on all different levels, and maybe also Julianne adding the animals, as you mentioned. I don't know if you had a chance to listen, but Professor Julianne Meisner said that you cannot talk about social determinants or economic determinants of health of the animals in a way, but actually it is very relevant, because those who are living in poverty, they will have also many problems of taking care of their animals. So, Stavros, we are here already after the final hour. It's here. It's almost 7:10 p.m. So I think that we are going to close now. And again, thank you so much for being with us. It was a fascinating day. And Stavros, I'll be visiting probably in about a week, so I'll be in touch with you in Arizona. So
okay.
Thank you very much, everybody. And again, tomorrow there is the field trip. So those who didn't sign, you cannot leave the auditorium. You're not going to get any dinner. Okay. Thank you so much, and hope to see you tomorrow.